Hello, everyone, and welcome to today's webinar on public health modernization. I'm Dr. Julie Morita, and I'm the Executive Vice President of the Robert Wood Johnson Foundation, the nation's largest philanthropy dedicated solely to health and health equity. The foundation is 50 years old and has from the start been a trusted and nonpartisan source of information on policy aimed at improving health and the healthcare system. Today's conversation will focus on a couple of topics I've worked closely on for years, acknowledging the importance of public health, not just during emergencies, and also the importance of keeping our nation's public health infrastructure financially sound and modernized. Before joining the foundation, I worked for 2 decades at the Chicago Department of Public Health, ultimately as commissioner. I understand firsthand the challenges local public health departments face and the barriers to health equity that are inherent in our health systems. Conversely, I've also seen how equity-centered modernization and investment can strengthen public health services and help people lead healthier lives and create stronger, more equitable and resilient communities. But public health has been chronically underfunded in the United States for decades, with less than 3% of healthcare spending going for public health and prevention. On top of that, public health data has long overlooked the needs and experiences of historically marginalized communities. COVID-19 brought these long-standing issues into stark focus with devastating consequences for communities, especially in low-income communities and communities of color that have faced a long history of structural racism and economic barriers. The good news is that right now we're facing an unprecedented moment to change that trajectory. There's new funding available to support public health modernization efforts. And this funding, if used effectively, has the potential to help the federal government truly advance health equity across the country and improve health outcomes. To discuss this, I'm pleased to introduce Dr. Jeffrey Levi, Professor of Health Policy and Management at the George Washington University's Milken Institute School of Public Health. He's the principal investigator of an initiative called Aligning in Crisis, funded by the Robert Wood Johnson Foundation. This initiative works to find ways for healthcare systems, public health, and social services to work together to offset the impacts of COVID-19. It also focuses on rebuilding the economy and addressing the ongoing impact of systemic barriers to health, including structural racism. Jeff, I turn it over to you now.
Thanks, Julie, and I'm really happy to be here and to share some of what we've learned in this project, particularly around the public health system and how we can take advantage of some of the lessons from the pandemic to really build a stronger and more resilient public health system and therefore, by extension, more resilient communities. Next slide, please. So, the bottom line here is that when we think about the U.S. public health system, we're really talking about something that is highly decentralized. We have nearly 3,000 local health departments, and there isn't a standardized approach to what a local health department should be providing and how it should be structured. While we need to have health departments that can be reflective of local community needs, there are also some very basic protections that every American should be served by. And the truth of the matter is, in this current system, where we have not set specific standards for local health departments, where you live does indeed determine your level of protection. And we saw some of that play out during the pandemic. Now, we can resolve this by developing a long-term investment strategy that knits together the diverse health departments across the country and provides predictable funding and focuses on equitable, resilient community building. And that's really what I'm going to be talking about today, how we can build that kind of resilient system that serves communities across the country. Next slide, please. So there are certainly some critical lessons from the pandemic itself. The U.S. public health system really lacks certain critical infrastructure elements. We certainly saw, above all, that the data systems, the laboratory capacity, and the analytic tools and it's not just the equipment and the software and hardware, but it's also the staff are insufficient to provide both national and local real-time situational awareness and the ability to ramp up our capacity in an emergency. So that's a critical piece. We were always a little bit behind the curve in knowing what was happening with the pandemic, and therefore could not build our response as rapidly as we needed to do that. And this really derives from a lack of investment at least a lack of consistent investment in governmental public health. We tend to see fluctuations in spending based on current emergencies. So whether it was Ebola, whether it was H1N1, whether it was the post 9/11 period, we saw major increases in public health funding, but those were not sustained over time. You don't build core capacity for public health when you have those kinds of fluctuations in funding. And that was just from the federal level. We see similar variation across states in terms of how much they are able to invest or willing to invest in public health. So our failure to address those underlying, and the other piece of this, in addition to the infrastructure, is that over time we have failed to address the underlying inequities in the health of Americans, and that created elevated risk for certain populations, and therefore undermined our ability to contain the pandemic. So those two pieces, we didn't have the public health infrastructure, and we didn't over time invest in addressing the core health needs of all communities and reducing inequities. Those created almost a perfect storm for some of the challenges we faced as a country in this pandemic, and why we had higher rates of severe illness and death in the United States compared to other countries. So next slide, please. What will it take? So there are a variety of approaches to think about, but the first and foremost on the next slide is recognizing that we need to standardize public health programs and services. There is a consensus in the public health community that we need to be thinking about foundational public health services. So some of that, and you can see that at the bottom of this graph, are approaches that we often think about, and we actually fund directly: communicable disease control, chronic disease and injury prevention, environmental public health, maternal and child health, and access and linkage to care as core functions of public health. And we tend to fund those as programmatic initiatives. But what we often neglect is at the top of this graph, which is the core public health infrastructure: the assessment and surveillance, the emergency preparedness, the policy development, communications, community partnerships, and so on. Those are the critical pieces that need to be in place in a community in order to be able to deliver those programs on a routine basis, as well as to be leveraged when we have an emergency like a pandemic. And that's where we've failed to invest, because most funding going to health departments is for programs and not for that core infrastructure. And whether it's state funds, local funds, or federal funds, that tends to be the bias in how we fund things. And health departments have had to beg, borrow, and steal, in a sense, from those programmatic dollars in order to build that public health infrastructure. Going forward, we really need to think much more about starting with the public health infrastructure, which then will better support those programmatic areas we all care about and are much more visible. But without that infrastructure, we will have weaker programmatic interventions, therefore not able to address some of the core concerns, health concerns in communities. So this graphic and the definitions is about to be updated, and the additional infrastructure element that is not on this graph but that is critical is around equity. And equity actually surrounds the entire program, that you have to think about equity being integrated into every element of foundational public health services. So again, what will it take? On the next slide, we can get a sense of the kind of staffing needs that are needed. So on the left side of this slide, you see that since 2006 or so, 2008 or so, we have lost 15% of the state and local public health workforce. So even as we were coming into a pandemic, we had fewer people on the job who could be mobilized to respond to the pandemic. So we were starting a little bit behind to begin with. On the right side is analysis that's been done by the Staffing Up Project, which is a project of the Public Health Accreditation Board. And they attempted to look at the kind of staff that would be needed at state and local health departments and to address these foundational public health services, and particularly the foundational capabilities. And the shortfall they found was about 80,000 positions to address those foundational needs, divided between state and local health departments. So that's a huge gap that we need to begin to fill. Obviously can't be filled overnight, but it needs to be filled. Next slide, please. So what will that cost? When we think about 80,000 positions, how much does that cost? There have been a number of analyses done to assess what it would take to build from our current level of spending just to address the foundational capabilities, those core infrastructure issues. So one study done out of the University of Kentucky identified that we are currently spending about $19 per capita on those foundational capabilities, and that to fully fund those foundational capabilities, we need to spend $32 per capita, which is a shortfall when you multiply it by 330 million people of about $4.5 billion. Senator Murray's Public Health Infrastructure Saves Lives Act would create a mandatory funding stream that would provide this kind of investment. Whether it's a mandatory funding stream or how it ramps up over time is less important than recognizing that for state and local health departments to create these positions, they need to have predictable funding so they can be sustained over time. You can't recruit people for jobs that have one-year funding, at least quality people who want to make a career of public health. And if we're going to entice people to come into public health and make this a career and make this a life's work, we need to offer them consistent funding. And that's for the people side, but also just for the capacity side. If we don't have predictable funding, we'll never be able to solve those infrastructure gaps. Next slide, please. Now, this is going to be determined on a state-by-state and community-by-community level as to what are the gaps in public health infrastructure. Every community is slightly different. What their needs are for foundational capabilities is going to vary, and what they already have in place is going to vary. So this money also, in addition to being predictable, needs to be flexible. But we also know that we have to hold people accountable, and we need to provide incentives and, frankly, other types of leverage to make sure people move in this direction. And that's where the notion of accreditation comes in. So the Public Health Accreditation Board has developed standards similar to what we would see for hospitals. So the concept here is that just as we expect hospitals to be accredited, and we are not likely to want to go to a hospital that isn't accredited, shouldn't health departments also be accredited? Right now, it's a voluntary process, but as the accreditation movement moves forward, there's more and more focus on foundational capabilities. And in the revision of their accreditation standards, the Public Health Accreditation Board is now focusing specifically on those foundational capabilities. And in the future, states and local health departments that cannot deliver on those foundational capabilities will not be able to achieve accreditation. So CDC could require it. It could be incentivized. Certainly funding needs to be provided so people can meet those standards, but one way or another, in exchange for this flexibility, we really need to be thinking about how to push this accreditation process. Next slide, please. So the good news is we have a lot of money to start with in response to the pandemic. Congress has already provided major infusions of funding to respond to the crisis and to rebuild public health. So there was $7.7 billion for public health workforce in the American Rescue Plan Act. CDC has announced that come April, some of that money has already been released, but $3 billion has been held back for this rebuilding process, and that certainly would be a start to providing resources to local and health departments to build their capacity. There's also another $1 billion in the fiscal 22 conference agreement for public health infrastructure. And the appropriations committees have provided over the last 4 or 5 years consistent investments in supporting data modernization, one of the critical pieces around public health infrastructure. So Congress is beginning to move in that direction. I think the challenge we see people are concerned about is how we can telegraph to states and locals that there will be consistent investment over time so that as people are rebuilding their health departments to meet these accreditation standards, to address these foundational capabilities, that they will be able to sustain that over time. Next slide, please. So if we're going to have a modernized public health department, if we're going to have a more resilient nation, because this is not just about building health departments, this is about allowing health departments to provide those foundational public health services so they can create healthier communities, more resilient communities, more equitable communities, so that the next time we are healthier now, and when we face the next pandemic or the next emergency, we will be more resilient. And so that's why it's going to be critical to provide ongoing funding for those foundational capabilities, to focus on equity within those foundational capabilities so communities really are much more resilient, and to focus on what communities need to rebuild trust in both state and local public health and federal public health agencies. Because if we invest this money in a way that is responsive to communities, I also think we'll build stronger partnerships with communities and we'll rebuild some of the trust that has been damaged, to be perfectly honest, during the pandemic. And rebuilding that trust has got to be a critical piece of the rebuilding process. So I will stop there and see if we have any questions. Back to you, Julie.
Thanks, Jeff. That was a really fantastic overview of the situation. I was having PTSD as you were going through the slides, just reflecting upon my own experiences in Chicago with the peaks and troughs of funding that we had over time. Particularly the peaks would be post public health emergency, whether it was H1N1, Ebola, post 9/11. There's huge surges of funding, and then it would just dissipate over time. And then we were really never able to build that core infrastructure in the way that was necessary to really engage with community, meet community needs, and really understand what was going on. So just really thank you for lifting up these critical issues and the importance of funding core infrastructure and the foundational capabilities. We will have, at this point, we really have an opportunity to open up questions to the audience. I'll manage the questions, and it looks like we already have one in the chat here. So let me read this to you, Jeff. We have, can state and local governments be held accountable for the effective use of public health funds? So the question is, how can state and local health governments be held accountable for effective use of public health funds?
So that's the critical question. It may be, the $7 billion question from the American Rescue Plan Act investments. I think there's a growing feeling that there are several ways that this can be done. One is to start with transparency so that we know how funding is spent and so that communities know and can hold their health departments accountable as money is coming in and can be part of the process of determining how that money should be spent. So transparency, engagement of communities in decision making so that they are part of the process, and in a sense, it isn't the big bad federal government holding a local health department, but their communities holding them accountable for investing in areas that will be important to the communities to improve their health. But I think ultimately there is also accountability to the federal government. When the federal government is making investments of this level, it's critically important to be able to show Congress, to be able to show the public that we are getting what we invested in. And that, I think, is where the accreditation process comes in. That, right now it's a voluntary process. Whether the CDC should incentivize people to do this or require people to do it, at least being able to show that an objective assessment is finding that you are building toward being able to address all those foundational capabilities is something that we should be able to expect from a level of investment like this. And because accreditation is, just like with hospitals, is renewed on a regular basis, we will know whether the investment is being maintained. We'll know whether we can, and we can also adjust those requirements as our understanding is changing or as the broader public health need changes over time.
Yeah, thanks so much for that, Jeff. It's interesting. When I was at the health department, we were accredited twice. We went through the first round of accreditation, and then we went through the second round for reaccreditation as well. We found it to be very helpful because it helped us review our processes, the systems that we had placed to make sure that we were really meeting these standards that had been established. And so we found it to be very helpful. It was also a lot of work, and it cost a lot of money to actually do that, to be accredited. And so this concept of having flexible resources that are sustained over time to support foundational capabilities is really necessary, because it took a lot of time and energy from staff as well as resources to really make sure that we could be accredited and that we were meeting those standards. So I think it's really important to lift that up, that the standards are necessary to be and having a process to be accountable is important, but also providing the health departments with the resources that are necessary to accomplish that is really important as well. I also have a question for you, another question just of my own related to this concept of equity. And I think we've seen how equity really played a critical role throughout this response, that it became clear that our responses were not equitable in the beginning and that they needed to be more equitable. And so the responses were modified over time. It sounds like the public health foundational capabilities are also now more focused on equity. Can you elaborate a little bit on that and share what that actually looks like and what it means?
Sure, and I would answer that in two ways. One is equity needs to be infused in every aspect of what we are doing. And so it isn't as though equity stands to the side as a foundational capability, although it needs to be called out, but also how we look at data systems, what kind of data we collect, how we analyze that data is also critical to being able to identify equity issues in the community and demonstrate that we are addressing them. But it plays out into every aspect of what we do. And I think that plays out both in terms of how we develop things programmatically, but most importantly to me is the foundational capability of community partnerships. Some people will think of it, and that community partnerships is sort of falls in two categories, both of which were critical and both of which were lacking in many communities in the pandemic. The one is the kinds of partnerships you need across sectors. So you have to be able to have relationships with the healthcare community, with businesses, with education, all of whom, if you at the beginning of a pandemic need to be introducing yourself to the leaders of those communities, you're way behind the eight ball there. And having those relationships makes it easier to work out policies and strategies and leverage resources. But the other part of community partnerships to me is the residents of a community and engaging them in understanding what is important to their health. And I've heard over and over again, and Julie, you probably can come up with examples of this because I know you've done that systematically in Chicago, that public health comes in with an idea, well, the data says this and we're going to make this a priority, and you talk to people in the community and say, yeah, we want to get there, but actually there's something else that's driving our distance from public health, our distance from government. And you need to address that first to build the trust and for people to feel engaged. And had there been stronger community relations and not just relations, community engagement in decision making, a lot of the pandemic response in some communities would have been designed entirely differently. and we would not have seen some of those inequities that we saw up front.
Yeah, Jeff, thanks so much. Again, I just keep thinking back to my experiences in Chicago. Prior to my departure, we had started engaging with community in a more meaningful way for our public health planning, just a baseline, not for public health emergencies. And so we established these relationships with community organizations and communities themselves to inform what the public health work should actually look like moving forward. So when the pandemic struck, the city, the mayor's office, the health department leveraged those relationships, really relied on those relationships to help with contact tracing, with testing, with vaccine, helping make sure that people in the community understood what they had their questions answered. The health department knew what the questions were. Also, what were the barriers that they were experiencing so they could really tailor the programming to actually get into the communities and really address their needs. So it was not only just sharing information with them, but also listening and then incorporating their needs and thoughts into the solution themselves. So important. And these relationships were established well before the pandemic. And it was because we actually pieced together money from a bunch of different places to support this kind of work. So ongoing support is really necessary to really allow other health departments to do the same kind of work.
Right. And I just want to emphasize that piecing together shouldn't be our funding strategy for these core capabilities.
That's right. That's right. Thank you. So I have another question for you. How have states used public health funds in innovative ways during the pandemic? And what can policymakers learn from those efforts?
Oh, that's a really good question. And of course, immediately the mind goes blank when you're trying to come up with examples. But I think the principal one to me is the creative engagement of relationships with community-based organizations. Some of the work that I do is looking at multi-sector partnerships across the country that have been developed to address ongoing health needs and underlying social determinants of health. And what we've found is where those partnerships existed, they could be leveraged and in a sense turn on a dime. And health departments have never been able, in an emergency like this, you're never going to have enough staff on hand. You need to leverage everything in the community. And so the creative use of relationships with community-based organizations has been incredibly important. I mean, the other piece we've seen is the use of what we sometimes call intermediaries to do some of this work. So many states have public health institutes that are nonprofit entities that may be independent or may be associated with an academic institution that were able to receive, states and local health departments were able to give them some of their federal resources to do some short-term hiring, to do for contact tracers, for outreach workers, that sort of thing. So I think that's one piece of it. But health departments have also been, incredibly creative in doing outreach of their own and learning over time how to make, for example, testing or vaccinations much more accessible for people. So in the Washington area, libraries have become major public health entities, to the point where some librarians are beginning to say, we also have a core function here too. But they were distribution sites for tests, for home testing, or they were distribution sites for rapid testing. They've become distribution sites for all sorts of education programs. So thinking about those kinds of relationships much more creatively, I think, has been really important.
Thanks, Jeff. I have another question. This is from Trent, from Senator Mitt Romney's office. Can you please elaborate on the assessment projecting a need for 80,000 public health workers? What activities would they be engaged in? Is that relative to the pre-pandemic level? How do productivity enhancing innovations play into this assessment?
So, this is part of the Staffing Up project, and if I could, I would figure out a way to get you a link to it where you can see more detail about how this was determined. I think what's most interesting for people who are thinking about the state and local level is that this summer they are going to be releasing, this is a general national estimate, and this summer they are going to be releasing a calculator so local health departments can determine based on what their current staffing is, what their population size is, and the kinds of staffing needs they might have. And so it can be really defined down to the local level. I think part of what we're going to learn from this exercise is that there may be a minimum size you need. So how many epidemiologists does a health department need? Well, some health departments are so small that they may not be able to support, they may not be a large enough community to support a full-time epidemiologist. So can health departments share that service? And so I think this project and this kind of analysis is going to get people to start thinking more creatively about how to effectively use these resources. This is really about the staff and capacity that you need to leverage a lot of sort of the innovations that are out there as well. So on a parallel track to staffing, we need to be thinking about data modernization and making sure that every health department doesn't need to design their own surveillance system, their own databases, even their own appointment systems for vaccinations. But we can standardize that, and that can become much more efficient. But what we can't standardize, in a sense, is having the people who can do the analysis of these data so that it is directly usable by the local community. And that's where the staffing needs come in. But I think what we'll find when we look at this project, when you look at the details of this project, it's that analytic capacity that is lacking in so many health departments. It's not just a matter of who can do data. This is not data entry. This is really data analysis.
I think that's a really great point to lift up, that the skill, it goes back to the foundational capabilities. That when you look at what those are, then you can get a sense of what the skills that are necessary for the workforce itself. And if you standardize them based on the foundational capabilities, it makes it more clear the skill sets that it requires. So as health departments are hiring their staff, they're looking for the critical skills that are necessary. We have about time for two more questions. And so the next is from an attendee asking to clarify the difference between workforce, infrastructure, and staff as it pertains to the 7.78 in the ARP.
So I would say workforce and staff are interchangeable. And I think in the American Rescue Plan Act, the definition of workforce is not just for state and local health departments, but also the broader public health workforce. So community health workers that may be working for community-based organizations. So whatever it takes to reach people, to engage them in public health activities, as well as the staff that a health department may need to be able to do their core work. Do community health workers work for health departments? Do they work for community-based organizations? Might they work for a health system? That's going to vary depending on what's happening on the ground in the local health in a local community. And the way those dollars have been distributed has been pretty flexible so that localities can really address their need. What's been really important in that first bolus of money around community health workforce, that whether it's going to health department employees or community-based employees, is the administration has been really clear in saying that the workforce needs to reflect the community that they are being served, that are served. So the work, that $7.7 million is around workforce and people. So it's about people. There's separate investments in lab capacity and data, those kinds of hard things that are needed. But we can't just build the hard thing, build the data system and build the labs unless we have people to work in those labs.
Yeah, that's great. The one great example of infrastructure that I think of often is immunization registries. There are 50 states in the United States, and each state had a different immunization registry. And so they didn't necessarily talk to each other. So what we're talking about is when we improve data, public health infrastructure, we're talking about improving some of the electronic systems that capture the data, whether it's immunizations or whether it's disease surveillance kind of data. That kind of information is also, those kinds of systems are part of the infrastructure. I have the last question for you, Jeff, and that is, how can policymakers ensure equity is at the center of public health modernization efforts? And are there any efforts that Rwjf has supported regarding data modernization with an eye toward equity?
Well, I'll let you answer the second part. I think it's a value, but it's also an expectation that should be created. So making sure, you know, and what I just mentioned around the workforce dollars is if you make clear as an expectation of funding that the workforce reflects the diversity of the community that is being served, I think that is one way of doing it. The second way that I feel really strongly about is that health departments should not be speaking ex cathedra about what is needed and how money should be spent. That community representatives need to be at the decision-making table, not just about setting priorities, but also determining how the money is spent. You know, I got into public health through HIV work, and the Ryan White program is a perfect example of, you know, and that is since 1990. So we've been doing it a long time, and health departments know how to do it, where communities are brought to the table to help both set priorities and determine who should get that funding. Community health centers have requirements that a majority of their board be representatives of the community. And so if a board is dominated by community members, that's the ultimate authority in decision making. So we know how to do it. And I strongly believe if we're going to get equity at the center of public health, then it is listening to communities who we are trying to serve and have them help us set those priorities.
Yeah, that's a critical point, Jeff. Thanks for lifting that up. So I'll take the second question, which is about what RWJF is supporting related to data modernization with an eye toward equity. So at the end of 2020, we actually funded some quick strike grants to actually look at what could be done to help improve public health data overall. Those quick strike grants actually informed a public health commission that we brought together in the middle of last year to make some recommendations regarding what needed to happen to make public health data systems more equitable overall. And a lot of those recommendations really focused on how the data are used in terms of how the data are collected, how they're analyzed, how they're disseminated, and keeping community in mind again, because it's critical for community to benefit from these, but also to be a part of some of the systems that capturing the data, analyzing the data, reporting this data, and also dissemination of the data as well. So that there were recommendations related to that, but there were also recommendations related to the importance of disaggregation of data, because we saw this play out early in the pandemic, that we just had inadequate data as it related to who was being most severely impacted by the pandemic, whether it was by race or ethnicity or other socio-demographic characteristics. And so the commission made those recommendations, and following that, the foundation actually funded several large initiatives supporting work related to community engagement with data systems, public health data systems, and then also some more related to data disaggregation. So we didn't fund everything that all the recommendations, we didn't have enough resources to do that, because the recommendations weren't just meant for philanthropy, they were meant for federal government, state and local government, private sector. There are many of us who have important roles to play as it relates to data modernization. And so RWJF started some work in that space, but are really working hard now to get this information into other partners' hands so they can then take on their roles and responsibilities to really modernize the public health data system. Okay, so at this point, it looks like we have finished our questions. At this point, I really want to thank you, Jeff, for the insights that you shared today, for engaging in this conversation that is so important for us to be having. And, and as I mentioned at the beginning of the session, the Robert Wood Johnson Foundation has a long history of providing nonpartisan, evidence-based information to policymakers. And so we're proud to be able to contribute information regarding the issues we discussed today. For example, last year, the foundation commissioned this national commission that I talked about, and it was charged with identifying what private and public health investments are needed to improve health equity. The commission also issued recommendations, as I mentioned, about at the federal, state, and local level, and we're really hoping to move forward with those, encourage others to take on their roles and responsibilities. And we're searching, you can find more information about this work by going to our website at rwjf.org and searching for the phrase "better data for better health." Again, I want to thank everyone who participated in our discussion today. I appreciate your time and your interest. We'll send everyone a recording of this webinar with links to additional resources as well. And we're also going to send you a brief anonymous survey. We really appreciate your completing it, for it helps us plan future events. So thanks to everyone and have a great afternoon.